Hi friends, once again a warm welcome to my YouTube channel Future Midwife. In the last few classes, I discussed about the fetal monitoring technique. That means still we are in the track of fetal monitoring technique. Today's class also belong to one of the fetal monitoring technique, that is cardiotocography. Actually, what do you mean by this cardiotocography, or what is the word meaning of cardiotocography? Cardio means fetal heartbeat. Toco means uterine contraction. And graphy means we are recording the fetal heart rate and uterine contraction with the help of a graph. So that is the word meaning of cardiotocography. So when it comes to the definition, it is nothing but we are monitoring the fetal heart rate and uterine contraction with the help of a machine called cardiotocograph. Usually we perform it during the pregnancy, especially in the last trimester of pregnancy. The cardiotocography is shortly we called it as CTG. The CTG can be performed antenatal time, also at the admission to the labor room. So that means when the mother is in the labor room, especially in the intranatal period, usually we check the CTG during the first stage of labor process. Usually the time duration of CTG will be 30 minutes. So during the CTG, we always prefer the mother to be in left lateral position in order to prevent the vena cava compression. Here we'll discuss about the purpose of CTG. The purpose of CTG recording is to identify when there is concern about fetal well-being to allow intervention to be carried out before the fetus is harmed. The focus is on identifying fetal heart rate pattern associated with inadequate oxygen supply to the fetus. Next, we'll see the indications of CTG. These are alteration in fetal heart rate present during auscultation if fetal heart rate is less than 110 beats per minute. High risk delivery like polyhydramnios, preeclampsia and eclampsia. Induced labor if there is decreased fetal monitoring and if there is a twin pregnancy. In these all cases, we perform CTG. Next, we'll see the contraindications of CTG. These are uterine hemorrhage of unknown cause, placenta previa. It may also be associated with a small risk of fetal injury, placental hemorrhage, uterine perforation, and vaginal infection. Here we discuss about the articles needed for CTG. First of all, we need a cardiotocograph. Second one, we need a ultrasound transducer. Third one will be a toco transducer. Next we have a ultrasound gel, then paper, that is graphical paper for monitoring, and the last we need a belt in order to tie the transducer over the abdomen. Next, we'll discuss about the method of CTG. So, we can perform CTG in two ways, external method and internal method. In the external method, as I said you just before, with the help of a transducer like ultrasound transducer and toco transducer has to be placed over the abdomen. In that, the ultrasound transducer has to be placed over the fetal heart rate area. So especially in the left scapular region, we have to place the ultrasound transducer, and this toco transducer usually we keep in the fundal area of the uterus. Then with the help of a cardiotocograph, externally we are monitoring the fetal heartbeat and contraction. So this method we called it as external method of CTG. When it comes to the internal method of CTG, this method can be useful if membrane has ruptured either spontaneously or artificially. Use an electronic transducer connected directly to the fetal scalp through the cervical opening and is connected to the monitor. This type of electrode is sometimes called a spiral or scalp electrode. Internal monitoring provides a more accurate and consistent transmission of fetal heart rate than external monitoring because factors such as movement do not affect it. Internal monitoring may be used when external monitoring of fetal heart rate is inadequate or closer surveillance is needed. Here we reach the basic interpretation of CTG. In that, first we'll see about the baseline fetal heart rate. That means the heart rate between the uterine contraction. The heart rate more than 160 beat per minute is called fetal tachycardia. So the fetal heart rate below 120 beats per minute is called fetal bradycardia. Usually it is indicative of fetal hypoxia. The constant range of fetal heart rate between 110 to 120 beats per minute will be indicative of any cord compression. Next CTG characteristics is baseline variability. When fetoplacental function is normal, the fetal heart rate has term variability greater than 7 beats per minute, at least for acceleration of more than 15 beats per minute in 20 minutes, either spontaneously or in response to Braxton Hicks contraction or fetal movement. Next is the response of the fetal heart rate to uterine contraction. The fetal heart rate will normally remain steady or accelerate during contraction. Deceleration of fetal heart rate, if recorded, must be assessed for their relationship to uterine contraction. In case of early deceleration, the fetal heart rate start to decline before the uterine contractions start. Then it will come to the normal baseline once the uterine contraction fade or stop. The early deceleration can be occurs in case of fetal head compression. I will explain once again the early deceleration, that means which begins at or after the onset of a contraction and return to the baseline rate by the contraction has finished. An early deceleration is commonly associated with the compression of fetal head. Next we'll see the late deceleration, which begins during or after a contraction reaches its lowest point after the peak of the contraction and has not recovered by the time that contraction has ended. Sometimes the deceleration has barely recovered by the onset of the next contraction. The time lag between the peak of the contraction and the lowest point of the deceleration is more significant of severity than the drop in the fetal heart rate. This always indicates fetal hypoxia and the physician must be informed. Next we'll see the complications of CTG. These are premature rupture of membrane, preterm labor and nerve injuries. Lastly, we'll discuss about the roles and responsibility of midwife. These are explain the procedure to the patient, provide privacy, maintain a safe, comfortable position for the client, gather all articles needed for CTG. The woman must empty her bladder. Patient should be lie in semi-Fowler's or left lateral position. Fetal heart rate is then maintained for approximate 20 to 30 minutes. It is important that fetus not be in a sleep state during entire procedure. This is the basic information about the CTG. So I hope all of you understood about the basic information of CTG. The elaborate way of interpreting the CTG will be taken in the next class. So till that, take care. Bye bye.